Thanks so much for asking me to come along and have a wee chat with yourself, and congratulations to Graham as well. It's quite a history in education. I did Google him, so I have to admit to that. So thanks again for asking me to come along. I'm Michael Moneypenny. I am the current president of ASPE, the Association for Simulated Practice in Healthcare. I'm also a consultant anaesthetist, and I'm also the Associate Postgraduate Dean for Skills and Simulation at NHS Education Scotland. Yeah, I think ASPE is a fantastic organisation. I think I would say that, of course. I think we pride ourselves on our multi-professional, multidisciplinary membership, which is growing leaps and bounds because of the increase in use of simulation as a modality in health and social care.
Just as a reminder, there are quite a few membership benefits. There's the IRIS opportunity, publication in the journal, and we have a conference coming up in November.
That's right. So there's a conference the 6th to the 8th of November. The conference topic is very close to my heart, and it is all things being equitable, diversity, inclusion, and simulation. So again, I think very topical, very worthwhile, and again, anybody listening, be more than welcome to come along. Yeah, so I'm not sure I've got a favorite slide, but this is certainly a very good slide. I really like the division of the bits into the workforce at the top and the system and work design at the bottom. So basically the people at the top and the system at the bottom, although I think you and I both appreciate that people are part of the system, isn't it? So if we start with the workforce, then I think what we have in simulation is, I think some people call them bright sparks, or others call it, I think, islands of excellence in a sea of mediocrity. And I think that's true for much of health and social care, whatever it is you're looking at, and it's true for simulation as well. So I think in some places, people will be and are, in fact. So I know the hospital I'm working at the moment, they do use simulation for recruitment and selection of nurses, for example, as a way of having a look at, not as a pass-fail thing, but another way of having a look at the people who are applying to work at our place. We know that people are using it for development and assessment in some instances, and you might think of simple simulations such as basic life support or advanced life support, which are not immersive, not that realistic, but they show that people can do the skill that's required of them. It is used in remediation and support. So again, I know the GMC does some of that work. We do some of that work up in Scotland at the Scottish Centre for Simulation and Clinical Human Factors, where we get doctors who are referred to us from the various parts of the deanery when they felt that they're not performing up to the standard that's expected of them, and then they go through exercises with us. So we do an acute medical emergency scenarios exercise, and then they go to Dundee and do a ward simulation exercise. But I also know that this is not the case throughout. This does not happen everywhere, and it should do. It should be happening in places. Why wouldn't you, before you employ somebody potentially for a lifelong career at your place of work, why wouldn't you have a little look and see what they're like when they're under stress, or what are they like when a patient, in this case, a simulated patient, complains? What happens when someone comes and tells them that they've made a mistake? How do they deal with those things? At the moment, many places just have a simple interview process, and that does not tell you that stuff. I find it interesting that I can get the same amounts of CPD sitting in a lecture theatre for 6 hours, let's say, as I would do for being involved in a full day simulation, actively participating, taking part in a debrief, and really, really deeply learning something, both from my own performance and then also, of course, from observing others. And I know, again, so in some places, so in Australia, for example, you get different amounts of CPD based on what the things that you're doing. So it's not just 1 hour is equal to 1 point. So I think from the question, we're doing some of it in some places. We could be doing more. We should be doing more in more places. I was at a talk where a lady came over from the US who's involved in the setting up of a new children's hospital. And they figured because they ran simulations beforehand, before they actually built the emergency department, they figured they'd saved several hundreds of thousands of dollars by making sure that the place was built the way that was going to work. We definitely should be using more simulation for equipment, device, and technologies. Um, I have an anesthetic machine that had an on-off switch next to the suction. The interesting bit is what we found in simulation is that people were switching the anesthetic machine off in the simulator because they thought they were switching on the suction. And then it happened in real life. For many of these things, I'm just looking at the procedures guidelines and checklist the same. So it makes absolute total sense to run these through in simulation to iron out any problems. I do sort of mental simulations with the people at my work. So I'll do a 5-minute mental simulation at the start of every list and say, what if, and then we get the quick reference handbook out and we go through our checklist. And it makes a huge difference and people feel engaged. I have an idea of people being trained every day. So we train every day, even on the job. And that's what simulation can help do. So again, we're there in some places with some people. We're definitely not where we should be in terms of, and I suppose we're going to get onto this in terms of outcomes. But in terms of, people enjoying the work that they're doing, us saving money, not harming people, and making sure in terms of the environment, for example, that it actually does what it's supposed to do.
I think that what we don't do well is pointing out those savings. It's very difficult to point out an invisible saving, isn't it? Like the improvement in design, the avoiding using the bad bit of kit, and just that end user aspect. There's a wonderful saying which I enjoy, which is the future is here. It's just not evenly distributed. And it's a bit like that in terms of these islands of excellence. There's all this great stuff going on, but we still need to somehow bring it together a little bit more. And just because some things are intuitively good rather than measured to be good doesn't actually put a ban on them. Without wondering about the semantics of the thing, how do you think we're doing in actually demonstrating return on an investment and actually completing that menu there on the right?
Yeah, I think I kind of agree with you more. And I suppose, again, to plug ASPE a little bit, I mean, this is the kind of stuff you come to ASPE, come to the conference, join the special interest groups. This is the kind of thing that people are talking about, And if you look in the literature, particularly around simulation for practical skills, so McGahy's work in particular, you can't talk about practical skills without mentioning him. He has shown, very high level return on investment in terms of length of stay in a hospital. There's some of the things we're doing well. There's some literature on the stuff we're doing, and we're not doing very well, and many things in terms of looking for those outcomes. And again, partly and probably mostly it's financial, because people are not paying the money at the moment or not investing in the research which will allow us to show the differences. And so much of what we're doing is anecdotal. First chest drain in a real patient. First epidural, a real patient. First spinal, a real patient. First intubation, a real patient. And I have harmed patients, I'm not saying that every mistake I made I wouldn't have made if I made it in a simulator, but I'm sure there are mistakes that I have made in my career that I would not have made if I'd made them in a simulator first. The culture of simulation, which is not really spoken to in this thing here, is that we are learning from our mistakes, that we are human beings. We learn from our mistakes. It's not that we can make as many mistakes as we want. It doesn't matter. It matters. We know it has impact. But we learn from our mistakes, and we learn from our mistakes by thinking deeply about what happened, both for ourselves and the wider system, and how we and the system can be better, which is not something that people do off their own backs. And it's not something that I've seen happen anywhere that simulation isn't embedded, because that's the kind of thing that comes out of the simulated experience, those kind of thoughts, that kind of psychological safety where you can admit that you had no idea what you were doing at that stage, or you were totally misunderstood what the person had said to you, and that's why you did the thing that was, in retrospect, the wrong thing.
I feel that simulation and human factors are intricately intertwined, both in learning and discovery in healthcare. And that's, I'm not suggesting we're going to untie the knot, but I think that that's a journey we are still probably not much into making. And I just wondered whether you had any thoughts on that.
Yeah, yeah. So I totally agree with you. When I started at the simulation centre in Scotland, it was called the Scottish Centre for Clinical Simulation. No, it wasn't. It was called the Scottish Clinical Simulation Centre, in fact. And then when I took it over as the director, I felt very strongly that we needed to bring human factors into that, because that's really what we're doing with simulation. We are looking at improving the system and personal well-being, which is what human factors, is looking at, human factors ergonomics. I think what simulation lets us do, which Stephen Shorrock's work talks about, this whole, which I really recommend looking him up. He's got a really nice website called Humanistic Systems, so I really recommend him. He's also on Twitter. Follow him.
He's also at the ASPE conference.
Yeah, what Steve really looked at was work as done, work as imagined, work as described, work as prescribed. This kind of model of work, and what many of us at the higher echelons have is work as imagined. We can only imagine what goes on at the coalface. Perhaps we were there some time ago, maybe 10, 15 years ago. We also were at the coalface doing our thing, and we feel that perhaps we still know what goes on, but we don't. 10, 15 years is a long time, so you don't really know what's going on at the coalface anymore. And I'm not saying don't do walkarounds. People do walkarounds, don't they? And there's no doubt there's a Japanese word for that. Go into the workplace and all this kind of stuff. And that's still not the same as work is done. And I'm not sure if Steve's actually looked at this yet. He probably has. What we're looking at is work as simulated, which is very similar, or can be if done well. And I think that's the very important underlying thing, because simulation done badly is just very bad. But if it's done well, you can get close to work as done, which allows you to see what actually happens in the system when the alarm goes off, when the patient collapses, or even in normal work. Things are just happening. What's happening? Let's just bring this patient through. Let's get this patient through from ED up to theatres, a normal day. What actually happens to that patient? What's the patient journey like? That's part of simulation. And I think that's one of the powers of simulation, which is that's one of the reasons why I renamed the center to include the human factors in it, because that's the focus, I think, of where simulation is bringing us. Simulation helps us improve, optimize the system, and optimize personal well-being.